Well, hello, everyone, and thank you for joining us today. We were going to wait a couple of more minutes, but I see that uh, we already have a good number of attendees, so we're going to get started. My name is Shaista Malik. I'm the Executive Director of the Susan Samueli Integrative Health Institute, as well as a Professor of Medicine in the Division of Cardiology. I'm happy to moderate this session of SSIHI's Research Webinar series. Before we start, I want to review a few Zoom housekeeping items. This session is being recorded, so you'll get a prompt to agree to being recorded. We will send all registrants the link to the recording, and then everyone will remain muted to limit distractions. To communicate with us, please submit any questions in the Q&A feature on the bottom of your screen. And we will hold a Q&A session at the end of the presentation and hope to get to all the questions during that time. Anything we don't get to, we may have the opportunity to send an email with answers. So the Samueli Institute is committed to whole person research, education, and clinical care. Our interdisciplinary researchers are dedicated to exploring the science of disease prevention and treatment. We bring this series to you to share the promising integrative health research that's being conducted right here through the Institute's esteemed Samueli Endowed Chairs, our pilot studies grants, and the Samueli Scholar Awards. To date, the Institute has supported 57 distinct research investigations in 32 pilot studies to enhance our understanding of integrative practices. And for more information about those studies, please visit our website at scihi.uci.edu. So our speaker today is Dr. Gary Deng. Dr. Gary Deng is a Samueli Endowed Chair in Integrative Oncology and the Director of Clinical Affairs at SSIHI. He's also a Professor of Medicine at the UCI School of Medicine and Associate Director of the UCI Chow Family Comprehensive Cancer Center and Program Director of Integrative Oncology at UCI Health. His expertise lies in integrative whole person approach to health, supporting patients across the continuum of cancer prevention, treatment, and survivorship. Since 2003, Dr. Deng has been a pioneer in integrative medicine and created the first of its kind integrative oncology program at Memorial Sloan Kettering Cancer Center in New York. He's the principal investigator for federally funded research on acupuncture, yoga, and botanical agents, and has led the development of education programs that have trained numerous physicians and researchers in integrative oncology. His scholarly works include clinical practice guidelines, clinical trials, reviews, and textbook chapters. He's the past president of the Society of Integrative Oncology, the founding medical director of integrative medicine at Memorial Sloan Kettering, and a former professor of medicine at Weill Cornell Medical College. He earned his medical degree from Beijing Medical University in China and a PhD in microbiology and immunology from the University of Miami. He completed his clinical training at the University of Texas Medical Center at Houston and research training at the UT Anderson Cancer Center. So please join me in welcoming Dr. Deng.
Thank you, Dr. Malik. It's a pleasure for me to present in this Samueli Institute for Research Webinar. So our overall mission is to study integrative therapies and also study the science and also how to apply it in clinical practice. So every research project, we always start with a real world problem, right? So this is a very common scenario in cancer care. You got a cancer survivor, breast cancer survivors, after treatment, she's cancer-free, but she got all these problems. This is probably the number one scenario we see in our clinic. fatigue, hot flashes, joint pain, abdominal bloating, constipation, insomnia, worry about recurrence, and all that. If you treat each symptoms with a medication soon enough, she'll be on like 10 different medications. So is there a way we treat them with a low burden, gentle therapy that will take care of this problem without adding more pill counts or other side effects to the patients? There is such a thing, which is acupuncture. Historically, acupuncture has been used to treat a variety of symptoms, but in recent years, a lot of research focus on especially relieve certain symptoms in the field of oncology, these particularly common symptoms. So just because it's been used for hundreds or thousands of years, it's not enough because we have to accumulate evidence using modern scientific research methodology so that we can have a better idea whether it works, how it works, for whom it works. This is what I'm going to talk about today, is to walk us through from the clinical problem and the strategy of conducting a line of research so that at the end, we, number one, change clinical practice and make acupuncture part of standard cancer care. And number two, we know more about the science behind acupuncture. Even though it's an ancient modality, actually, there are a lot of modern neuroscience research going on in this field. So for those of you, a lot of us know about acupuncture. For those of you who don't know, acupuncture is the insertion of these very fine needles into certain body points and then manipulate the needle either manually with physical force or with electric current or with heat. And these points are not randomly picked on the body. From classic texts, they define where you find these points. There are also modern research showing the anatomy below and beneath these points. They are kind of different. You can think about as a conduit for us to tap into the deeper neurological circuitry. And I'll show some data towards that end later. So far, acupuncture has been studied for these common symptoms in cancer patients. Dry mouth, because during radiation of the head and neck cancer, the salivary glands are damaged, and these people have very dry mouths. They cannot eat properly, they have dental problem, they have malnourishment, also very uncomfortable. Hot flashes, breast cancer patients are on hormone treatment, their estrogen is blocked, they go into another menopause, and they have hot flashes. Chemotherapy-induced nausea, vomiting, pain, fatigue, constipation, insomnia, right? You can see these are very common problems experienced by a majority of patients. So there is a big need out there for new intervention tools. Let's talk about the evidence pyramid, because oftentimes we hear working in this field of integrative health or complementary alternative medicine in the past, patients always tell us, oh, I have an uncle's friend who got stage 4 cancer, didn't treat, and then he's cancer-free now. So these are what we call, anecdotes. They are not really evidence because there are a lot of factors that go in there. Sometimes the story itself may miss some critical piece of information. So what we do is we look at the fact and data and put them into this pyramid, and at the bottom are these experts' opinion. Like Dr. So-and-so think this is the best treatment, or this authority said this should be done this way. That was very last 2 centuries ago. And then there's a systematic evaluation with case report, case series. Basically, you find individual real world cases. And then you do a more systematic review of these cases. Those are retrospective or prospective cohorts. And then you got controlled clinical trials. Because in the cohorts, there are a lot of variables. The patient may do well, not because of what you think is making them doing well. It could be some other factors, right? So you have to have a control group. And then the best individual level data came from randomized controlled trials, because this way you eliminate all the other variable, all the other factors, only focus on your intervention. So in this presentation, most of the data I talk about came from these randomized controlled trials. On top of that, once you have a critical mass, a cumulative number of randomized control trials, you can summarize the data and do systematic review and meta-analysis, which means you pull the data together and analyze them. Once you got more certainty, you develop clinical practice guidelines and also do health technology assessment and influence public policies. So this is the natural progression of how to build from evidence to change clinical practice. And when you talk about clinical trial, they also progress through a sequence of pilot study, usually single arms, and then just to see how things goes. And when you have some data, you do a phase 2 study, smaller randomized control trial showing some sign it's actually working. And then you do a definitive phase 3 trial and then do systematic review and meta-analysis. So let's start with the dry mouth, xerostomia. And as I mentioned, this was a common problem in head and neck cancer patients going through radiation treatment. And I did one of the very early study using acupuncture at the Li2 point, which is on the finger, on the index finger, and to see, number one, does it actually stimulate saliva production? And number two, what's the underlying neurological circuitry that's being activated? So on the right-hand side, you got the production of saliva. These are medical student volunteers. On the left-hand side is the functional MRI brain imaging, which shows which part of the brain is activated, which tends to show up as yellow or red, or which part is suppressed, which tends to show up as green or blue. Right? So the image is actually my own brain because I went to the MRI scanner as a first patient, just want to make sure it's safe and I can stand up and come out safely. One interesting anecdote is when we're doing the acupuncture in the MRI suite, the needle, once you move the needle close to the core, the needle actually will bend because there's so much magnetic field there. Anyway, what we found is when you do unilateral stimulation at the Li2 acupuncture point, you got bilateral insular cortex activations. And insular cortex is on the side of your head. We're curious what in real world these cortex do. They're involved in signal processing. And when we asked the neurosurgeon, because there are lots of neurosurgeons at Sloan Kettering, they do brain tumor operation. We asked them what happens in your operation when you stimulate this. They said, well, if you stimulate the insular cortex, they're called gustatory cortex. People will start chewing movement, even though they are not conscientious about that. And then some of them will make saliva. So our hypothesis is when you stimulate this large intestine 2 point, you somehow tap into that built-in circuitry already built in for the brain to stimulate production of saliva. And there is a correlation between the MRI changes and saliva production, which is shown on the right side. And then we look at the clinical results. So these are clinical trial, randomized control trial of patients with head and neck cancer. And we saw after acupuncture, these are subjective reports. Do they feel their dry mouth got better? And we did see significant change between the group, which are marked in red. And then later on, other groups continued this line of research. And this is a group down in China, Fudan Hospital Cancer Center in Shanghai. They did a large randomized control trial and to prevent xerostomia during radiation. And you look at the curve, these are unstimulated production and stimulated production of saliva. And for people who receive acupuncture, they make more saliva. And those are sub-objective endpoint, which means they actually measure the amount of saliva produced. And this is another later one done in conjunction between MD Anderson Cancer Center and the Shanghai Fudan Cancer Center, a multi-centered randomized control trial. Again, this is more for treatment than prevention. And they found people who got acupuncture at the end of the treatment, they have less xerostomia. And if you pull all the data together, they did not see statistically significant differences between the true and the sham, but they saw difference between the true and usual care control. So there is definitely a little placebo effects there because there's a sham control, but there is more than just placebo effects. Another one is the aromatase inhibitor related hot flushes, right? Because these people, their hormones blocked, so they have a lot of hot flushes interfere with their sleep, they're wet, they get sweating during the day and the night. So this was a study I conducted, again, randomized control study for people, breast cancer patients with hot flushes. And the blue curve is the sham acupuncture, the yellow one is true acupuncture. During sham acupuncture, you stimulate the body point that is not on an acupuncture meridian or classic acupuncture point, and there's no needle penetrating the skin. But the patients are kind of blindfolded and they couldn't tell whether it's real or sham, right? So this is to remove the expectation and the placebo effects. What's interesting, you can see everyone got better regarding whether they're getting sham or true acupuncture. About 20% better. This is a kind of a known effects, the placebo effects. But if you keep going through the time, the sham acupuncture group, the symptom will just stop there. But the true acupuncture group will continue to get better. And this was a crossover study. So people in the sham acupuncture group actually got crossover to true acupuncture, and they experienced further improvement of treatment, which is the dip of the blue line here. And then what's interesting also, this effects last 28 weeks, even after the acupuncture treatment was stopped. This was also interesting because recently there was a JAMA paper published on acupuncture in 800 Kaiser patients, and they found it improved these elderly patients' lower back pain function. Again, there, if they were getting medications, usually you stop the medication, the problem come back. But when those patients in that study, when they did acupuncture, they remain improved even when acupuncture stopped. Several months later, they remain functional. So exactly why acupuncture led to long-lasting effects, there are all kinds of hypotheses. One is it's not a simple neurological reflex. There may be some neuroplasticity involved, which means the stimulation of acupuncture may change the rewiring of the neurological circuitry. So the neuron connection is plastic, which means moldable, which is good in the sense that you may give people treatment and then you can stop treatment and people continue to do well. So after that, an Italian group in Bologna, they did a randomized controlled large study, hundreds of patients, and they observed here they use usual care control, which is the blue line, and the yellow line they saw improvement. Again, the improvement lasted for many months afterwards. So at my previous institution, Sloan Kettering Cancer Center, when breast cancer patients report hot flashes, the medical management using medications has a lot of problems and side effects. So the breast oncologist usually just refer them to us. This is the number one reason we got our acupuncture patients referral, because breast cancer patients has hot flashes. If you give them other medications, you tend to give them hormones, which is contraindicated in breast cancer patients. And later, this is my colleagues, Dr. Mao, also did a similar study, but here you got four groups. You got sham acupuncture, electroacupuncture, gabapentin drugs, and then a placebo pill. So what's interesting is it looks like, if you look at it, acupuncture works better than sham acupuncture, and works better than pills, works better than placebo pills. Again, here, if you stop the treatment and follow them for like 24 weeks, the acupuncture, even the sham acupuncture group, the effect stays. But if they are taking the pills, once you stop the pills, the symptom come back. So apparently, this created some kind of, I would call neuroplasticity. Even placebo pills create that because the mind, shows the connection between mind and body. When your mind is focused on, I'm getting benefit, somehow it become a self-fulfilling prophecy because actually there is probably rewiring of the neurological circuitry. And we also see that a lot in meditation research, like mind-body therapy, meditation research in studying the neurological networks in the brain. And not only that, they found that there are responders and non-responders. If you have certain polymorphism in these genotypes, and you tend to respond to acupuncture. But for those patients, the pills has no differences. So apparently, the neurological circuitry has been is different. And while drug has a very peripheral effects, acupuncture probably have very central neuroplasticity effects, and that is influenced by the polymorphism of your neurotransmitter metabolisms. So here's another one, chemo-induced nausea vomiting, which used to be very common with the advancement of chemotherapy. Now, it's not that big a problem for some therapies, but for some chemo, these patients still experience a lot of nausea vomiting. Here, there are so many randomized control trials done, so people can do meta-analysis. They summarize the study from all these 10, about 38 randomized control trials, about 2,500 patients. And they look at the acute vomiting. If you look at the aggregate of the data, it favors acupuncture than plus urocare than usual care. So this is actually one of the indication a lot of insurance company will cover acupuncture even before Medicare cover acupuncture for lower back pain. Insurance company will cover chemo-induced nausea vomiting based on this cumulative data. Here's the one for delayed nausea vomiting. Again, the aggregate data favors acupuncture. And another common problem in cancer patients, actually in the general public, is insomnia, right? A lot of us have sleeping problems, either having a hard time fall asleep or staying asleep. Sometimes because our mind is running, cannot stop, and we have too many things to think about, things I have to do tomorrow, and so on. We cannot shut it down, and that interferes with the sleep. So here is a meta-analysis of 10 randomized control trial of 750 patients, and you can see the aggregation of the data favor acupuncture versus sham acupuncture. Here's another one, functional constipation. A lot of people with constipation, if you do a workup, there's no digestive problem. There's no blockage, there's no any other disease. So the acupuncture has been shown in animal models to stimulate parasympathetic activation and promote digestive tract peristalsis. The gut will move more with the stimulation of acupuncture. So these are clinical trials in human, 28 randomized control trials, 3,500 patients. And if you summarize the data, it favors acupuncture versus sham acupuncture. Here's the comparison is acupuncture versus medication, right? There are these medication for treatment. There is a little bit difference from, there's a little bit better result from the medication, but it didn't, you see this little point didn't cross one, which means it's not statistically significant. But when you look at the side effects, the medication has a lot more side effects than acupuncture. So here is an example. Acupuncture may be equally effective as medication for constipation, but it gave patients less side effects. So this in clinical practice is favored, right? Patients love this kind of therapy because one of the main concerns they get any treatment is the side effects. So another one, which is more recent, is actually done at UCI in collaboration between Dr. Alex Chen and Dr. Malik's group. And they look at the cognitive function. These are so-called chemo brain. Cancer patients who had chemotherapy, the nerve is damaged by chemo, including the nerves, neurons and nerves in the brain. And they found people who get acupuncture, the cognitive function also improved compared to baseline. So this is an ongoing study happening locally here. And I also did a large randomized control study, multi-center, 300 patients with between Sloan Kettering Cancer Center and Fred Hutchinson Cancer Center in Seattle. And so these are bone marrow transplant patients who was getting treatment with treating myeloma and lymphoma with bone marrow transplant. But they have a lot of side effects, especially pain, because they create lots of mucositis. They're in pain. They have to give them opiates. Opiates use creates constipation and other problem, and eventually they may become addicted to opiates. So we did this large multi-center clinical trial. We gave patients acupuncture right after high dose chemotherapy for 15 days, and we evaluate them for day 7 and also day 90. And what we found is we look at the people who have to use opiates to control pain. These are the clinical team is actually blinded to the group assignment, so patients just get their usual care. When they need opiates, they have more pain, they use opiates. Right? We see a reduction between the usual care group and acupuncture group. It's 30% to like 24%. Unfortunately, it's not statistically significant. And then when we look at the overall symptom score, it didn't change much either. So this is a study where we actually did not see a big difference in the overall population. But this is a quite heterogeneous population. You got multiple myeloma, you got Hodgkin's lymphoma. They all get different chemotherapy regimens. And so we say, well, let's look at which group may be more likely to respond. These are subgroup analysis. And we found for people who are getting inpatient transplant, there's not much difference between the group. But if they're getting outpatient transplant, they actually have a bigger difference. These are actually significant difference. The outpatient transplant, patient who got acupuncture appears to use less opiates. So there are all kinds of speculation or hypotheses here. One example is in the inpatient setting, people are more likely to get opiates, right? You have a little bit, we give opiate. In the outpatient setting, when patients only have certain level of pain, then they will get opiates. So you actually see a bigger difference here. And then when you look at multiple myeloma patients, the Hodgkin disease patient, and the non-Hodgkin disease patient, in the Hodgkin disease patients, there's a big difference in terms of their pain score receiving acupuncture. So these are all leads and that needs further investigation. And so now we have summarized the major clinical trials, especially randomized controlled trials on common symptoms in cancer treatment. But now, how do we change clinical practice? You have to go from these trials to public policy or clinical guidelines, right? The development clinical guideline follow its own system. So I'll use this as an example, which is aromatase inhibitor related joint pain. These are, again, breast cancer patients taking letrozole, anastrozole, which reduce breast cancer recurrence because it blocks estrogen, but they also block estrogen that affects the joint, the collagen, the ligament, and so on. So they have lots of joint pain, so much. So actually here at UCI, a few weeks ago, I saw a patient who wants to stop this treatment because she said, her only or major joy in life is actually playing golf. But with this, she's a breast cancer survivor. With this medication, she's so stiff and painful, she couldn't play golf. She said, then what's the point of me? Even though I may have lower risk of breast cancer, but every day I'm miserable. I cannot enjoy anything a lot in life. What's the point, right? So this is where we actually can give her something to reduce the pain so that she can stay on this cancer preventive drugs. And when you study these, it actually follow a trajectory from acupuncture for other pain to early stage clinical trial to definitive clinical trial and then clinical trial guidelines. So this is a paper published, is again a meta-analysis of 29 randomized control trial, close to 18,000 patients. These are just acupuncture for chronic pain in general. They look at individual patients, osteoarthritis, which is just joint pain from old ages, chronic headache, and musculoskeletal pain in general. So this is compared to acupuncture, and these are also for this is for compared to usual care. This is control for sham, right? You can see the effect size is always smaller when you control when you compare to sham, but still it cross this line 0, which means acupuncture is more effective than sham. So we say, great, this is all the other musculoskeletal pain, headache, but what about this aromatase inhibitor joint pain? And so this is a study done again by my colleague, Dr. Bao, and she conducted 2 double-centered randomized control trial, both at the Johns Hopkins University of Maryland and also Sloan Kettering. So they found, compared to sham acupuncture, the patient's symptom score is better with real acupuncture. This is 71 patients. And then there's a large multi-center clinical trial. It's the pivotal or seminal paper published on JAMA, done by Dr. Hirschman's group. It's 11 sites. It's a cooperative group trial, right? You got the NIH involved in organizing like 11 sites, 220 patients. There's a big difference between when you compare true acupuncture sham or true acupuncture to usual care. Again, uh, there's always a difference favor acupuncture, especially when compared to usual care, the difference is quite big. And then, so here's a summary. The true acupuncture, 58% patients had a significant improvement in pain. In the sham, 33, usual care, 31. So in usual care, you still have some reduction. This is called a regression to mean, which means sometimes people seem to just get better by itself because when they seek help, you caught them when they have worse symptoms. And if the symptoms fluctuate over time, some of them will just get better by themselves. But true acupuncture apparently does a lot more than that, right? So based on this, we set out to develop these clinical practice guidelines. And we started very early in the development of the field, which I think is very important because we're doing a lot of this work, clinical work, research work, but outside the little world of integrative health, a lot of people don't know about that. And especially the community doctors, they never heard about acupuncture. They don't feel comfortable giving it. They worry about safety. But if we summarize the data and develop clinical practice guidelines from authorities, usually these are professional associations, you will give comfort to a big group of people. The entire oncology community will feel comfortable recommending that. That's how we can make it part of standard medical care uh, in real world. So these clinical practice guidelines are very important. I hope with in other field of integrated health, eventually we have all these clinical practice guidelines incorporated into the standard care in this respective field. So this is actually an iterative practice. You got a committee of experts. They have to have qualification there. They know how to do research methodology reviews, and then you formulate these questions, and you conduct systematic review, and then you read evidence based on strength of evidence and also benefit and risk ratio, right? So sometimes you can have low-grade evidence, but have a strong recommendation because the benefit far outweigh the risk. So this is a misconception. Sometimes in the real world, the doctors say, "Oh, there's no randomized control trials on this." But if something is very low risk in risk and there's a considerable benefit, even though it's only a single arm trial or small randomized control trial, it can still make a moderate recommendation. And then we develop recommendation and go around these circles. So over the years, we developed like 9 clinical trials. The most recent one, the Society for Integrative Oncology developed it together with ASCO. ASCO is like the authority of oncology in the US and also kind of in the world because the European or other countries actually they come to the ASCO meetings. So if they say something, it's almost like everyone say, "Oh, okay, we should do this." So there are guidelines on pain management. You can see this is for pain management and for aromatase inhibitor pain, for general cancer pain, acupuncture is recommended for peripheral neuropathy, surgical pain, right? And then also there's a guideline on anxiety and depression. And so mostly for post-treatment anxiety, acupuncture is recommended. For acute treatment, probably not strong enough or not quick enough. So far, we haven't had enough data to recommend it. And also for depression, we haven't seen, or at least there's not enough data from acupuncture trial making us to recommend acupuncture for depression. But for chronic anxiety, especially in survivors, this is recommended. And then you got fatigue. Fatigue is almost another universal symptoms. And they found after active treatment, these are post-chemo fatigue or post-radiation fatigue, acupressure and moxibustion actually can be helpful, which actually makes sense. In historical use, acupuncture is actually used to deplete, to drain the energy. Moxibustion is mainly to strengthen it, right, to give back. And so fatigue patients, they tend to be depleted. So you can argue acupuncture may not be so good because you deplete them further, but moxibustion can be very helpful. So this moxibustion, sometimes we cannot do moxibustion. We can just use heat or stimulation with an electric pad or a heat pad or hot water bottle that can give similar effects. So now, good, all good. We have come a long way from the early days where, oh, it's been used for 100 years, 1,000 years. They should just use it to do some small studies, then do randomized control studies. So you're very certain what you see is real rather than a coincidence. And then you got to accumulate enough clinical trials, high quality trials, you can actually make evidence-based recommendation that's disseminated to the oncology community, to cancer patients to change actual practice, and also win the trust and acceptance of this integrated whole person care approach to health from our mainstream medicine colleagues, right? Because when they see this, they are on board, they are on the same page, they support us, they support their patients. So this is all good, but we constantly push the envelope and see what next. You know, how do we elevate the level? Well, we already achieved a lot. How do we look back 5 years, 10 years from now and see, oh, we even push it even further? So this is what I see. The next step is we need to study more. We need to go dive deeper into mechanism, and we need to have some innovative ideas in indications, and we want to go beyond symptom reduction in cancer care, right? Because so far all the acupuncture study was in reducing symptoms. So this is a study I'm currently doing, funded by a National Cancer Institute, is using acupuncture to improve outcome in sepsis patients. So when we first think about it, we're giving patients with emerging sepsis acupuncture, and we're going to reduce ICU admission, so they don't deteriorate, they don't crash, and have to be transferred to ICU, or we save their life. Initially, people say, "Oh, this is so far-fetched. You know, how can that be? You know, you put the needle there, people's infection get better." So actually, there are a lot of animal studies, preclinical study, and neuroscience studies showing this actually can happen. So we did a phase two study. We're doing a phase two study, randomized patients with emerging sepsis to either true acupuncture or sham acupuncture, and we follow them for 30 days and to see number one how we can recruit these people. Number two, how many people went to the ICU in the acupuncture group, and how many in the sham group, and how many patients died within 30 days. And then we also check their biomarkers, catecholamine and inflammatory cytokine, because in animal study, they think this is how it works. So the animal study was actually published on Nature Medicine. It's a very high impact journal. They said dopamine mediate vagal modulation of the immune system by electroacupuncture. So I have a PhD in immunology, so I'm always interested in how integrated health, whole person health, to change the immune system to either help the cancer patient fight infection, in this case sepsis, or improve the efficacy of immunotherapy, right? Because immunotherapy is one of the breakthrough therapy now in cancer treatment. So here in the animal study, they have these animal models with peritonitis, and after surgery, one of the complications after surgery is you got infection in the abdomen and peritonitis. And if they give them sham acupuncture, they find the mice makes more cytokines, like TNF, IL-6. These are pro-inflammatory cytokines. If you give them electroacupuncture, you actually make less. So these cytokines are the culprit for cytokine storm, and then they got capillary leakage, and they drop their blood pressure, they got into sepsis, hypotension, septic shock, and they go to the ICU. And some of them have multi-organ failure, kidney failure later, and die. Right. So in this mice study, they found electroacupuncture actually reduced these cytokines. And then if you look at survival curve in panel A, these mice survive better. And then they look at the different. They basically try to tease out which part of the neurological system is involved. And I'll skip the details, and the paper is actually cited there. Basically, they see which nerve is involved and which organ is involved, right? And they use different blockers to achieve that. And they found it's actually the dopamine produced in adrenal gland. when you stimulate the SE36 acupuncture point, you lead to a vagal activation of the aromatic amino acid decarboxylase in the adrenal glands, which results in increased production of dopamine, which also lower the inflammatory cytokines. This actually makes sense because in clinical practice, when you have a septic patient going to septic shock, you give them dopamine through IV infusion. And it looks like if you do acupuncture, the body will make a little bit more dopamine endogenously. So maybe if it's almost like giving people dopamine earlier before they're clinically indicated, but you make the patient make the dopamine themselves. So this is another principle of integrative health is to mobilize the patient's own body to contribute to their own health, to their care. Right here, you find a way to mobilize the adrenal gland to make more dopamine, and then they don't go into septic shock. So they also look at it under microscope, all this molecular labeling and so on. And then there's another group in Harvard. They look at the neurological circuitry. So they found the neuroanatomic basis for electroacupuncture to drive the vagal adrenal axis. And this paper published on Neuron and Nature, these are first-tier papers. So they actually map out all this neurological circuitry. If you do ST36 electrostimulation, you stimulate the nerve, go up the spinal, go into the brain, and come down through vagal nerve to adrenal gland, and you make this thing. So I think this line of research exemplify the next level of acupuncture research, which means we're actually going, in addition to clinical outcome phenomenon, to actually mechanistic study, right? What exactly is happening when you do acupuncture that leads to your clinical outcome? So this is the study I mentioned earlier. We're going to give them acupuncture and measure the outcome. We're going to measure their cytokines. Also, we're going to use survival as input. So far, to my knowledge, this is the only acupuncture trial in the United States with survival as one of the primary endpoint. So we're moving from just symptom management to actually saving people's life, extend their life, not only improve their quality of life, but also improve their quantity of life. So I would say, in summary, I see that's the future. We're working really hard on this, but where are we now? The state of science of acupuncture research in oncology. I think we're almost like, the proverbial blind man feeling the elephant. We're finding the pieces here and there. Acupuncture does this, do this, help this kind of nerve system, but we still have not got the whole picture yet. But I think with continual research, we will be able to have to achieve that state. So thank you so much. I'll be happy to answer all the questions.
Thank you, Dr. Deng. That was amazing. What a great overview of, how acupuncture research has led to incorporation in guidelines, and then looking at the future and really getting into novel mechanisms and changing hard outcomes. So that's just wonderful. We have a couple of questions. So, all the people who are participating, please feel free to put in questions into the Q&A. And so the first question that we have from an attendee is, could you describe, I think, the protocol, so the typical number of treatments, frequency, duration, and timing of acupuncture in managing cancer therapy-related symptoms?
Okay, so that's always, acupuncture in clinical practice is pretty variable, right? Each one do different things. There's several ways of approaching the actual protocol used in acupuncture. The earlier study, they tend to be very regimented because at that time, if you get a grant application, you got all these variables, the protocol acupuncture can change from one patient to another based on the therapist's judgment. You're going to be shut down. The grant reviewer say this is not rigorous enough. Your intervention is not even standardized. So the earlier study tend to use standardized protocol. But later, once acupuncture is more well known, the reviewer loosen up. So now usually is a combination of historical use, experts' opinion of acupuncturists, previous data. There are always some previous study for the same indication, and you learn from what they use. and then come together, and there is a core component, and then you got some improvised, individualized points. So that's how the intervention protocol is formulated.
Great. The next question is, they say, thank you for your talk. What are your thoughts about why acupuncture benefited Hodgkin's lymphoma patients, but did not for the other patients?
So we don't have solid data, so we can only speculate. And one example is their regimens are different, and those patients also are healthier. So our hypothesis is, for people with less pain, less healthier, tolerance, in general, better condition, acupuncture gives them the edge and push them over to better results. Put this way, if the pain is very severe, these are acute severe pain, acupuncture may not have strong enough to push them over to cross the threshold. That's our hypothesis, but it's speculation.
Great. And so then the next question is more of a practical standpoint, especially with inpatient. Is there a platelet count requirement for patients on active chemotherapy? And then how are you managing this in your ACTION trial too, which are, fairly ill patients?
Historically, there is a cancer patient while they're getting treatment, or even leukemia patient, they have very low platelet counts. They can have very low neutrophil counts, so they're prone to infection or bleeding, right? So historically, there is a cutoff, right? If platelet is lower than 50, neutrophil count lower than 500, don't do acupuncture. But then we look at it and say, well, this is more expert opinion. There's no evidence for this, right? We practice evidence medicine. Where's the evidence? And there is no evidence. But these people are still getting IV phlebotomy. The needle goes in, and acupuncture needle is less traumatic than IV needles. So why do we have this precaution? So we challenge that. We said, well, this is not evidence-based. So in the ACTION trial, in the sepsis patient, we actually have no, in the past, it was the exclusion criteria. In this trial, there is no exclusion criteria on low platelets and neutrophils, because we're confident based on hundreds of thousands of cases done in clinical trials. We think this is an extremely low risk. Also, these patients are already septic. They are loaded with bacterial load in their body already. And now you say the acupuncture introduce a little bit more bacteria in there, it pales, because one of your main concern is causing infection. But these people are infected, they have a severe infection already. So this is actually a great model for us to test and challenge that. And we can document safety. We're going to remove that restriction. Of course, under conditions, like you have to be totally aseptic, very careful with bleeding, point selection. So you can, if there is bleeding, you have to stop, you can stop it. So of the 40 patients we have done before, in this trial, we have not observed a SAE based on from acupuncture.
Great. Thank you. The next question is, they thank you for the talk. They're curious about your thoughts on the use of psychotherapeutic approaches to impact similar outcomes in cancer patients, and are the effect sizes they're saying in their psychotherapeutic interventions are promising. Has there been a head-to-head comparison? Are there studies on combining acupuncture and psychotherapeutic approaches?
Yes, there is a study. I didn't have the space to show it. Actually, my colleague, Dr. Miles from Kettering, he did a study compare acupuncture and cognitive behavior therapy. And we also compare acupuncture and massage therapy, right? So in cognitive behavior therapy for insomnia, they're kind of equivalent, but the responders are different. There are certain kind of patient response to cognitive behavior therapy, which is think about the dynamic intervention, and some people respond to acupuncture. So I think the mechanisms are different, and that's where further research on identifying responders will be good, because then you can look at the patient, take a profile, and say, oh, you're more likely to respond to acupuncture. You go get acupuncture. The other patient, you say, oh, you should get cognitive behavior therapy. So there are ongoing research in that area.
That's great. Any data for pediatric oncology patients?
Unfortunately, I'm not familiar with that. There are some data, but as you know, cancer is a disease of elderly patients. Pediatric patients, if you look at the whole population, it's probably only like 5%. So there are not a lot of patients. There are not a lot of acupuncture research. I had a colleague Dr. Kelly at Columbia University. She's a pediatric oncologist. She did some studies, but they tend to be small. You don't have enough patients to do large studies.
Um, this is from Dr. Harris. He says, wonderful talk, Dr. Deng. Does the long-term benefit of acupuncture extend to all of the comorbid symptoms in survivors or just for some symptoms? And yeah, I was very curious as well. It was interesting to see you showed a 28-week out effect, showing sort of the long-lasting effects. So is there more benefit in some symptoms versus others?
I think we don't have enough data to have a definitive answer to that, but we do see in some symptoms acupuncture leads to long-lasting improvement. One example is for nasal congestion, right? Allergic neuritis. I actually do it in my family member who had this problem, and she has been using sprays, nasal sprays for years, but one treatment is gone and lasts a couple of years. So I cannot explain why just one treatment will resolve this long-lasting problem. That's why I said it's like a blind people feeling the elephant. There are a lot of things we don't know, but we do see that in clinical practice. Sometimes one or two treatments give you long-lasting results.
Great. And this is from Dr. Dusek. He said, Dr. Deng, what a great talk. Welcome to SSIHI. Any thoughts about acupuncture in the emergency department?
Dr. Dusek is expert in that area, so I think there are a lot of area you can use it, and the logistic is challenging. So I really congratulate Dr. Dusek was able to pull it off in the emergency room. He's conducting several large study in that setting. I have not had the privilege to do it in the ER, so I defer to Dr. Dusek on that.
That's great. Well, thank you, Dr. Deng. That was amazing. And I think you had a lot of engagement. And for those who would like a copy of the recorded session, we'll be emailing it out to all the registrants. We hope you can join us for our next research webinar scheduled in February 2026. Please look for an email to register in the new year. Thank you again for spending your lunch hour with us. See you next time.